Hello and welcome to the daily wrap-up here from the ESC Congress 2020, the digital experience from Amsterdam. We are almost at the end of day 3 of this marvelous Congress, and we would like to share with you the latest from science and education, from clinical trials, and also from basic science that has been presented to the cardiovascular world today. My name is Gerhard Hindricks from the Heart Center Leipzig, Germany, and I have the privilege to share that wrap-up together with 2 key opinion leaders from the field of cardiovascular medicine. And I would like to welcome Rick Grobbee from the University of Utrecht, Netherlands. Welcome, Rick. And Frank Ruschitzka from the University of Zurich in Switzerland. Anti-inflammatory therapy in the field of coronary artery disease has been in focus for several clinical trials over the past years. We have seen the CANTOS trial, we have seen the COLCOT trial, recently published both in New England Journal of Medicine and with the LODOCO trial that had been presented today to the public. There is another piece of significant evidence for anti-inflammatory therapy in patients with coronary artery disease. Rick, what was the LODOCO trial about?
The LODOCO trial was a sort of logic continuation after COLCOT, which was early after acute MI. In the LODOCO trial, there were 5,500 patients with chronic coronary disease included.
And there was a prospective randomized trial?
It was a randomized trial. The total duration was about 28 months. Interestingly, the trial started already in 2014, you know. Yeah. We had to wait 6 years for this to happen.
What was the primary endpoint of LODOCO?
It was a composite of cardiovascular death, MI, stroke, or revascularization.
So, and it was colchicine versus
placebo.
Dosage of colchicine was low.
0.5 milligram per
0.5. So it was low dose. What was the main outcome of that?
The main outcome for the primary outcome was about 30% reduction in occurrence of the event. And that was highly statistically significant. And in fact, across most of the secondary key endpoints, there were similar reductions in risk. I think apart from total mortality, which was slightly but not significantly higher, I believe, in the placebo, in the colchicine group.
So there was no statistically significant difference in total mortality.
No.
But I think most of the secondary outcome measures, they were almost all in favor of the colchicine.
Absolutely, and the drug seemed to be well tolerated also. There was relatively little dropout, I think less than in COLCOT, but then they had an open label run-in period in which about, I think, 10 or 11% of patients eventually dropped out.
But I'd be careful, though. Of course, safety is an issue there. And I tell you, in some countries in Europe, it's still not on the market. You get that. And then be aware of interaction with certain antibiotics, and colchicine is a relatively old and safe drug, but you have to get used to it and be aware of the interaction.
So if we look now to the lineup of COLCOT, of CANTOS, and LODOCO, is it all in line and goes into the direction of the usage of colchicine or any other anti-inflammatory medicine that has been tested in that field in the future?
Well, the history of anti-inflammatory drugs has not always been that positive. You know, we have methotrexate trials, which were not really recommendable. And CANTOS, I think that one of the concerns there was an increase in infections, but that was a very specific immune modulator, and colchicine is much more generic. And in this study, there was no indication of increased infection risks.
And the background of PCSK9 and others, you know, this is a trial that's 6 years old, or it was started back then. So we have to also...
I don't know by heart, but I think the representation of patients on PCSK9, given that the frequency of use in Australia and the Netherlands, where the trial was conducted, is not very high, and then the study is relatively old. So indeed, that's something to be looked into.
The study has been published this morning in New England Journal of Medicine, so we need to carefully read, we need to understand, to discuss, and to digest, and then to see how we put that into clinical practice.
Inflammation plays a role in atherogenesis. It's just we don't have the right anti-inflammatories yet. And maybe the old drug can learn some new tricks and will be useful. We'll see, but be careful.
Turning to another key topic in cardiovascular medicine for a minute, that's inpatient treatment, outpatient treatment. What type of cardiovascular disease, cardiovascular event can be safely treated outside the hospital? And there are news from the field of pulmonary embolism. There is a trial that has been presented today, Frank. What was that about?
Well, the acronym tells it's home PE trial. So, well, when we went to med school, arguably around the same time, our patients with pulmonary embolism, patients we would keep in the hospital. Now we aim at, well, at least in the low risks category, to send them home with an anticoagulation, no IV drugs necessary. And we manage roughly in Leipzig, in Holland, we're 1/3 of our patients are sent home. So based on what? We have to triage them, and this is what they tested in the home PE trial.
So they tested, I think they tested 2 different triage strategies in order to identify patients that could be sent safely home.
Perfect, exactly, because it was the American pragmatic way of yes or no, based on some hemodynamic stability or some other risk factors, the so-called Hestia rule, and if you and versus the PASI, the pulmonary embolism severity index, and they compared that, and they looked at the 30-day score of a combined endpoint of recurrent thromboembolism, but you see major bleed and death. And actually, they came out non-inferior at the pragmatic rule. So basically, you could send 1/3 of your patients safely home. That's, I think that's good news and helpful. So it was a triaging trial, basically. And these both scores, the pragmatic and the PASI, come out non-inferior.
Did they provide any information about the duration of hospitalization for the I would say, fast-track group that was low risk and sent home, and the traditional treatment?
The overall risk over 30 days with the major ones was 3.8. I haven't read the paper yet, so I have to see.
It hasn't been fully published yet. So that would be something that's really interesting to see what the impact of healthcare resource utilization is if you go to that path. We can take from the trial that it's safe to do it if the patients are screened appropriately, and I think it's an important information.
Absolutely.
Rick?
Very helpful.
No, certainly, and it's also timely, because we've seen in the last couple of months the pressure on the system and the need to have really the right patients at the right place, either at home or in the hospital.
And the right doctor.
And the right doctor, as always.
Okay, there has been a big data set presented this morning on arterial hypertension. Arterial hypertension continues to be one of the key drivers in the field of cardiovascular medicine for stroke, for coronary artery disease. And the University of Oxford, Qasim Rahimi, has this morning presented one of the largest data set analysis on the effects of pharmacologic blood pressure lowering for primary and secondary prevention. Rick, what was done in that analysis?
Well, first, let me conclude that this is really open science. Here is, you see what happens if investigators share their resources and combine that into a massive data set. And this is massive. 350,000 patients that were randomized in 48 trials.
350,000 patients?
Yeah, in 48 trials. These have been conducted over the last decades, and they are very different trials within those. Some are focusing simply on a comparison between treatment, no treatment, or treatment intense, non-intense. So it's a diversity of trials, but when putting this all together, the sort of bottom line is that there is a very consistent reduction in risk, about 10% per 5 millimeters of mercury for cardiovascular events, slightly higher, 13% for stroke per 5 millimeters of mercury, 14% for heart failure. And this is not only consistent per 5 millimeters of mercury, but also across baseline straight-up blood pressure, so all the way down to below 120. There's still this relative risk reduction.
And they analyzed that as far as I understood, the trial for primary and secondary prevention.
Yeah, they made a distinction between pre-existing cardiovascular disease, that's secondary prevention or not. And again, the same, approximately the same per 5 millimeters of mercury reductions in relative risk. We have to realize, of course, that the absolute benefits are likely to be much higher in the high-risk population.
1 millimeter mercury gives you 1%. 1% of cardiovascular death risk, actually, 1. Is that correct? Or?
Yeah, approximately, yeah.
What I don't know how you see it, but what I was wondering is, and that's true for even below 140?
Well, in this analysis, it's true below even 140. And if you want, you see even slightly larger, but not statistically significant reductions below the 120. You know, there's no drop-off there.
Yeah. Okay, well.
Frank, any strong impact on clinical practice?
Well, what he just said, it would, you know. That is, you know, our guidelines said, well, I always say, you know, the ideal blood pressure is as fast as I should drive in Switzerland. That's 120 plus 12% the wiggle room. It's 130, 133. So going below 140 would be okay for me, but below 130, I was a bit surprised. Let's see, that is how low should we go kind of discussion we're having. We'll see, it's interesting.
Yeah, and as a consequence, the sort of message is that we should perhaps look at blood pressure treatment as a risk modifier. And so if you have your risk because of a strong family history or high lipids that are difficult to treat, then blood pressure can modify that, even if the blood pressure is not elevated. That's the message.
I think that's one of the key messages and the key conclusion that Kazim Rahimi has called out.
But for coronary artery disease, I'd stay put for the time being. I think I'd be careful. So far, our guidelines still recommend being careful to going too low.
Okay. Yeah. Winston Churchill has said many, many smart things. One thing was that he said no sports. I'm not sure about how smart. How
they
smart
say it's not right.
Never engage in sports.
He was the captain of the cricket team or something.
So that gives us the bridge to talk a little bit about the 2020 sports and exercise ESC guidelines for patients with cardiovascular disease or being at risk for cardiovascular disease. They have been presented this morning, a marvelous document. And let's take off with looking to patients or citizens at risk for cardiovascular disease. Rick, what do these guidelines recommend in that direction?
Well, the bottom line is engage in sports and activity. So when you are healthy, when you have existing cardiovascular disease but are not at high risk for ischemia, and when you are elderly and fit, engage in sports because it is beneficial to your health, and the sort of crude recommendations are about 2.5 hours of modest intensity exercise, or about 70 minutes of intense exercise per week. So that would be like half an hour to an hour per day.
Mm-hmm. Any recommendation on sports in elderly citizens?
Yeah, there's the same reasoning there. If there is no evidence of high risk, that means ischemia during exercise, and they recommend the workup of subjects should there be suspicion for that, including imaging. But in the absence of that, basically the guidelines say go for it. Although there's repeat emphasis of patient engagement here. So it is a shared decision process, and it should be tailored to the individual patient's wishes and so on, but there is no restrictions.
Frank, what are the key messages from the sports, exercise, cardiovascular disease guidelines for patients with valvular heart disease and heart failure?
Well, first of all, on theoretical grounds, there's also a little bit concern about exercise in patients with valvular disease. Well, you increase preload, afterload, stroke volume. That may not always be necessarily a good thing. There are a lot of salutary benefits of exercise on the other hand. So it's more a consensus because we don't really have trials on that. So the consensus for valvular disease is that if you have mild disease and relatively asymptomatic, go for it. Recreational.
You can do.
Recreational, even competitive sports.
Is that true? Sorry, Frank. Is that true for mitral valve disease and aortic valve disease?
Yeah, it is. So, and on general, on that account, when you mention it, we know that from pathophysiology, regurg lesions are better tolerated than stenotic ones. And when we go for that, the moderate regurg, well, if you have a preserved LV function and mitral regurg and good functional capacity, well, go for it. But I always say, treat it as a dose, individualize it. There's no one size fits all. Gradually increase it, up-titrate the exercise dose, drug, what you give. So, and of course, in severe lesions, well, stay away from intensive sports activities.
Yeah, that's a good key message. Thanks for that, Frank. Rick, there was a very interesting recommendation in the field of hypertrophic cardiomyopathy and exercise.
Yes, and indeed quite liberal, if you wish. The recommendation is that in HCM patients with a low severity, that's ESC score below 4, functional capacity okay, no arrhythmias on maximal exercise, that they can engage in sports and even in competitive sports. Now, that's a minority, but it's clearly a change from the past.
Yeah, it's a new call for this patient entity.
Yeah.
Gentlemen, thank you so much for joining us today for the daily wrap-up, for great summaries and great comments. Thank you for joining us for the daily wrap-up to our audience. We hope that you're going to stay with us. Tomorrow we will have another exciting day, day 4 of the digital experience here from Amsterdam. We're going to take a look to another set of guidelines and interesting clinical trials, including the BRACE Corona trial. So join us back tomorrow. Bye-bye.